Welcome back to the Therapeutics Chronicles. I'm your host, Momin Wali, and today we are diving into a medication that's a staple in cardiology and one we encounter all the time across hospital and community pharmacy, Bisoprolol. If you are managing patients with heart failure, hypertension, or chronic angina, this beta blocker is probably already on your radar. But as pharmacists, we know better than anyone that not all beta blockers are created equal, and the differences in selectivity, dosing strategy, and safety profile absolutely matter. Today's episode is all about understanding Bisoprolol through a pharmacist lens. We will cover the mechanism, indications, dosing details, and the key pharmacist interventions that can make or break therapy. We will walk through real-world pharmacy scenarios and wrap up with rapid-fire Q&A to solidify the high-yield takeaways. Before we dive in, make sure you are subscribed. Share this episode with your pharmacy team and check out our Telegram and WhatsApp groups. Links are in the description. If you haven't connected with me on LinkedIn, now is the time. I would love to hear your Bisoprolol cases, questions, or pharmacist wins. Let's get into it. Bisoprolol is a highly selective beta-1 adrenergic blocker, meaning it primarily targets cardiac tissue, reducing heart rate and contractility with minimal impact on beta-2 receptors in the lungs and peripheral vasculature. That selectivity makes it a safer option for patients with mild to moderate asthma or COPD, though it is not completely risk-free at higher doses where beta-1 selectivity starts to blur. This matters in practice because we are often the ones fielding calls about whether a patient with reactive airway disease should stay on their beta blocker or not. So, why does Bisoprolol matter? It is one of only 3 beta blockers proven to reduce mortality in heart failure with reduced ejection fraction, the others being carvedilol and metoprolol succinate. That's not just symptomatic relief. We are talking real, measurable survival benefit. So when we see a heart failure patient and they are on atenolol or metoprolol titrate instead of one of the guideline recommended agents, it is on us to flag it and start that optimization conversation. In hypertension, Bisoprolol is effective but not first line unless there is a compelling indication, like coronary artery disease, heart failure, or post-MI status. We don't push it as monotherapy for essential hypertension anymore unless there is that added context. That's a good conversation to have with prescribers who may still be defaulting to beta blockers as step 1. Let's talk dosing. This is where pharmacists need to be especially sharp. For heart failure, the starting dose is 1.25 mg once daily, with slow titration every 2 weeks up to a target dose of 10 mg daily. And yes, we mean slow. Starting someone on 5 or 10 mg out of the gate can lead to bradycardia, hypotension, or even acute decompensation. Pharmacists are the checkpoint here. If you see an initial dose that's too high, you have got to say something. For hypertension, we typically see doses between 5 and 10 mg daily, with a maximum of 20 mg in resistant cases. But again, patient-specific factors come first, especially renal function, baseline HR, and comorbidities. Side effects, we see the usual bradycardia, fatigue, dizziness, and cold extremities. The fatigue can be frustrating for patients, and this is a place where pharmacists can really help with expectation management. Patients often stop the drug too early because they feel tired, but if we prepare them and explain that the fatigue often improves within a few weeks, they are far more likely to stick with it and get the long-term benefit. Beta blockers also blunt the adrenergic symptoms of hypoglycemia, especially in patients on insulin or sulfonylureas. The key warning sign of low blood sugar, tachycardia, can be masked. So for our diabetic patients, we need to make sure they know to watch for sweating, dizziness, or confusion instead. And of course, we never stop beta blockers abruptly, especially in patients with CAD or heart failure. Stopping suddenly can cause rebound tachycardia and hypertension, and in worst cases, angina or MI. If Bisoprolol needs to be stopped, we taper it gradually over at least 1 to 2 weeks. Let's talk interactions. Bisoprolol plus non-dihydropyridine calcium channel blockers, think verapamil or diltiazem, can be a problem. You get cumulative AV nodal blockade, which can lead to bradycardia or complete heart block. If rate control is the goal, like in atrial fibrillation, we typically prefer combining Bisoprolol with digoxin, not with another AV nodal blocker. Also watch for clonidine. If both are being used, taper clonidine first before discontinuing Bisoprolol to avoid severe rebound hypertension. There is also pharmacokinetic interaction potential with CYP3A4 inhibitors and inducers, but Bisoprolol's metabolism is not heavily CYP dependent. It is, however, renally cleared, so in advanced CKD, we want to monitor for accumulation and bradycardia, another area where pharmacists are monitoring and adjusting in real time. So let's put this into practice with some real-world cases. You are on hospital rotation and see a 65-year-old man newly diagnosed with heart failure with reduced ejection fraction, started on Bisoprolol 5 mg once daily. His heart rate drops to 42 beats per minute and he complains of dizziness. You catch that the dose was started way too high. You call the cardiology resident, suggest dropping to 1.25 mg and recommend titrating more slowly. That's a clinical save led by pharmacy. In community practice, you get a refill for a 72-year-old woman with moderate COPD who's been on Bisoprolol 10 mg for hypertension. She mentions worsening shortness of breath. You ask the right questions. Maybe it is her COPD flaring. Maybe it is the beta blocker. You suggest checking her pulmonary function tests and discuss dose reduction or possibly switching to nebivolol, which is also beta-1 selective and maybe better tolerated. The prescriber agrees to reassess. That's collaborative care at its best. Then there is the 55-year-old man post-MI, picking up Bisoprolol 2.5 mg and still running a heart rate of 90 beats per minute. You know, post-MI beta blockade is about getting to target heart rate, usually 55 to 60 beats per minute. You suggest increasing the dose if tolerated. That's not just symptom control, it is secondary prevention. Finally, patient counseling. This is where we really show our value. Patients should know that Bisoprolol does not work instantly. It takes weeks, sometimes months, to see full benefit in heart failure. Tell them not to stop it if they feel tired early on. Explain orthostatic precautions. If they are diabetic, make sure they understand that hypoglycemia signs might be masked and remind them never to stop it suddenly. Always speak to their provider first. So time to look it all in with some rapid fire Q&A. What is the starting dose of Bisoprolol in heart failure? 1.25 mg once daily. What is the target dose for heart failure with reduced ejection fraction? 10 mg once daily. Can Bisoprolol be used in asthma? Yes, cautiously, preferably in mild or moderate cases and at lower doses. Which calcium blockers should be avoided? Verapamil and diltiazem due to risk of additive bradycardia. Why do we taper Bisoprolol? To avoid rebound tachycardia and hypertensive crisis, especially in CAD. Does Bisoprolol mask hypoglycemia? Yes, it blunts the adrenergic signs, especially tachycardia. Does it improve mortality in heart failure? Yes, alongside carvedilol and metoprolol succinate. It is one of the three with proven mortality benefit. That's a wrap for today's episode on Bisoprolol. Whether you are adjusting the starting dose, catching an interaction, or educating patients on what to expect, pharmacists are on the front lines of making beta blockers safer and more effective. If you found this helpful, do not forget to subscribe, share with your team, and join our Telegram and WhatsApp groups. You will find the links in the show notes. And if you have made a Bisoprolol intervention that deserves a spotlight, I want to hear it. Reach out to me on LinkedIn and let's keep building better practice together. Until next time, this is Momin Wali reminding you, catch mistakes before they catch you, and see you then.